the webinar series by the Respiratory Research Foundation of India in association with Lupin. Today's webinar topic is going to be on interstitial lung disease. We have with us two eminent speakers. And from Sun Radiant, we have Dr. Yogesh. We have with us two eminent speakers, Dr. Narasimhan and Dr. Bhavin Jankharia. And to moderate this session, we have Dr. Srikanth from Coimbatore. I'll just say a few words about our foundation. This was Respiratory Research Foundation of India, was founded in 2001 under the chairmanship of Dr. Narasimhan, with the motto that TB is curable, asthma is controllable, and smoking is avoidable. And we have been involved in a lot of academic activities from the beginning, and we continue to do so in this lockdown period also. So we thank Sun Radiant and Chandrasekhar and Dr. Yogesh for the continued support. And just a few words about Dr. Srikanth. He is currently a senior consultant pulmonologist at Institute of Lung Care and Research, Hindustan Hospital in Coimbatore. He is from Stanley, MBBS from Stanley Medical College and MD from Institute of Thoracic Medicine. And he has been the lead principal investigator in various multicentric trials since 2003, almost 50 trials as a principal investigator. And he was formerly professor and HOD in PhD Institute of Medical Sciences and Research. So I'll hand over the mic to Dr. Yogesh so that he can guide us through the next.
Right. So thanks a lot, Ajay. So good evening, everyone. I'm Dr.
Just
Yogesh.
Before we go, I'd like to request all participants to mute their mics and stop their videos so that it will consume less bandwidth and the program can go on without any problem. It's a kind request. And if you have any questions, you can always put it in the chat window, and we can coordinate with our moderator to do it. Not a problem. Thank you. Yeah, Yogesh, on please.
Right. So thanks,
Somebody's
Ajay.
mic is
So
still on.
good evening, everyone. I am Dr. Yogesh from medical team of Sun Pharma, and it gives me great pleasure to extend to you all a very warm welcome on behalf of Sun Pharma for today's webinar. Topic for today's webinar is divided into two parts. First part is about radiological manifestations of ILD, and second part is about IPF management strategies. At Sun Pharma, we believe in connecting eminent faculty from around the world for exchanging their skills, knowledge, and experiences, which ultimately translates into patients' benefit. Today's webinar is one of such events, and with this idea, I take this opportunity to welcome our moderator for today's session, Dr. Srikanth Krishnamurthy. Mr. Ajay have already introduced him briefly, so I will just give some more introduction about him, and then I will hand over the session to him. So he was former professor and head at Respiratory Medicine Department, ESG Institute of Medical Sciences and Research for the interval from 2007 till 2012. He was part of greater than 50 respiratory clinical trials. He has various publications in national and international journals. Along with this, he has also organized and contributed as a speaker to various meetings, programs in pulmonology and clinical research. He is also president of Coimbatore Respiratory Society, also member of Indian Society for Clinical Research, as well as various national and international associations for pulmonology and critical care. It is our honor to have you here, sir. Now I will request our moderator to take this session ahead.
Thank you, Dr. Yogesh, and thank you, Dr. Ajay, for the introduction. Good evening, all of you. First of all, it's wonderful to connect virtually in this time of pandemic. We have been having a number of webinars, I think, the last 3-4 months, and I've personally seen quite a few of interstitial lung disease webinars going on. And well, to cut this long story short, interstitial lung disease, I think two key important factors in ILD that comes to a clinician's mind would be diagnosis, first thing, and the next is the treatment. Now, looking at the diagnosis was a huge challenge. It's been a huge challenge for so many years, because if you look at ILD, the etiology is so varied, the manifestations and presentations can be very confusing. Multiple specialties are involved, but then there is a commonality in everything, that is the lung scarring of the lung fibrosis and a very progressively downhill course of disease is something which we all seen. The second part has been the treatment part. We've all had a very negative outlook, if I may say, therapeutic nihilism. The moment you say ILD, especially IPF, okay, what are we going to do? It's almost like diagnosing a malignancy, and the treatment options were hardly any, if at all, I can say about 5-6 years back. And as a researcher, I have seen most of the clinical trials done in the early part with new drugs. The comparator arm would be like, standard of care, placebo, or you basically use whatever is available. But now we have really moved on from that part to a situation where we have two very, very promising and good antifibrotic drugs. So that change has really made a difference in the way our presentation will go today compared to what it was a few years back. So talking about diagnosis, I think the role of radiology is extremely important, and HRCT has revolutionized the diagnosis of ILD. And we are today able to pinpoint these are the possibilities, say 5 or 10 possibilities from 100 odd possibilities in the clinical diagnosis part. So with this, I would like to call upon, as Dr. Ajay said, we have two stalwarts today, both doyens in the respective fields. I will first invite Dr. Bhavin Jankharia. He is a consultant radiologist, trustee of the Radiology Education Foundation. He is graduated and postgraduated from Mumbai. He's had fellowships and training in University of California, Mayo Clinic, Royal Brompton Heart and Lung, London, and his special areas of interest is chest, bone, cardiac radiology, intervention, CT, and is also into the business of radiology and healthcare. A brilliant academician, has authored more than 5 books, 35 chapters, 57 articles. He is the editor-in-chief of Indian Journal of Radiology and Imaging, and his latest book is Computed Tomography of ILD. And he's also a member of number of associations. Importantly, he is the president of Indian Musculoskeletal Oncology Society and a past president of Indian Radiology and Imaging Association. I have had the privilege to listen to Bhavin quite a few times, as recently as a few months back in Pondicherry. And as all of you, I'm eager to await his talk. It's a pleasure to listen to you. Over to Bhavin.
Right. So thanks, Srikanth. Thank you, Dr. Narasimhan and the foundation and Sun Pharma for this opportunity. I never miss an opportunity to speak on interstitial lung diseases. So let's just start off directly. This is what we are going to do. I'll speak about the protocol for scanning, then about fibrosing and non-fibrosing ILD, cystic lung diseases, and a flow chart. And if we have time, I can run a quiz at paulev.com/refcaferentgen. So you can mark this down, but I'll keep mentioning this again and again. And it'll be a quick 10-minute quiz for 10 questions, and we'll find out who's got the highest points in that. All right. So remember, a good quality study is an absolute must. If you don't have a good quality CT scan to begin with, we'll end up making a lot of mistakes, right? So this is the scanning technique that has been approved by both the ERS, ATS, as well as the Fleischner Society, where we have these inspiratory volume scans that are required. All patients need expiratory scans. All patients need prone scans. All images should be soft copy. And if we have only films, then they should be 12:1. Now, in these times of COVID, right, we have a challenge. We don't want patients who come in for CT chest to be on the table for longer. And so for the time being, we're no longer doing expiratory and prone scans, but that is a temporary phenomenon for this particular time that we are in. But otherwise, this is what is required to be able to interpret our scans better. And to be able to be accurate about what we are seeing. Now, what are volume scans? So a volume scan is when you see the entire volume of the lungs from the apex to the base in this particular manner. Now, the way this works essentially is that we look at everything on the workstation. Radiologists countrywide, world over, no longer look at films. Films are only given to the patients for record. And because physicians want to see the films, because most of you would not have the ability to look at these soft copy images in a busy OPD. But otherwise, this is how we read. So we would sit on a workstation, we would go from top to bottom, look at the entire volume from the apex to the base. And then because this is a volume scan, we can see the same study in the coronal plane and in the sagittal plane as well. And I will show you how important looking at coronal and sagittal images is as we go along. So essentially, these are volume scans. These are important. And this is how we read scans of interstitial lung diseases. We also need volume inspiratory images when we're doing texture analysis. So for the last 4 months, we have been looking at all our interstitial lung diseases. Actually, it's since February, where we use Caliper, which is a software that's been around since 2013, extremely validated. And we score all of our interstitial lung diseases quantitatively, get a sense of the total lung involvement. For example, this patient has about 28% total involvement, and then you know the extent of fibrosis as well. And in patients who have airway disease, we use a combination of the volume inspiratory, expiratory images to figure out how much emphysema there is, how much air trapping there is, and all of this as well. But this is a topic for another day. So to diagnose interstitial lung disease, we have 9 signs, and I'll show them in a minute. But we use those to broadly differentiate fibrotic from non-fibrotic disease. These are the 3 signs of a fibrotic disease, ILD. We have reticular opacities, traction bronchiectasis, where you have dilatation of the bronchioles here, and honeycombing, and we'll discuss this in a minute. And the non-fibrosing ILDs are ground glass, consolidation, septal thickening that we see here, ill-defined bronchocentric nodules, discrete nodules, and diffuse cystic lung disease. Now, diffuse cystic disease is not necessarily interstitial lung disease, but nevertheless, we look at this within that same context. Now, once we have differentiated fibrotic from non-fibrotic, the next question would be, is it IPF or non-IPF, right? That's really important. And we will hear more about that in the clinical talk. But nevertheless, our aim in life is, in a fibrosing ILD, we need to know whether it's IPF or non-IPF. And we now have the 4-bucket classification, both from the Fleischner Society as well as the ERS ATS, that tells us what to do when we have a fibrosing ILD. So like I said, we need to figure out whether it's IPF or non-IPF. If it's IPF, we would basically see 2 patterns, and I'll just describe them in a minute. And otherwise, it would be indeterminate or non-IPF. So the single most important sign that allows us to make a diagnosis of a fibrosing ILD is traction bronchiectasis. So please remember this. When we see traction bronchiectasis along with reticular opacities, it tells us that because of the retraction of the bronchioles, because of the fibrosis, we are able to define that this is a fibrosing ILD. Now, it could be at the periphery, as we see in the UIP patterns, or it could be proximal, as we see in this patient who has an old organizing pneumonia and has healed with fibrosis. So we see this here. Remember, all our patients with tuberculous fibrosis in the upper lobes also have traction bronchiectasis, because that's just a manifestation of the presence of fibrosis. So the single most important sign that defines fibrosis is traction bronchiectasis or bronchial-ectasis. So the moment we see reticular opacities and traction bronchiectasis, we then try and decide whether this is UIP/IPF, non-UIP/non-IPF, or indeterminate. And then we need to figure out which UIP it is, typical or probable. Typical UIP is characterized by the presence of honeycombing. So honeycombing is the presence of cysts with shared walls that are stacked one upon the other, starting in the subpleural interstitium. So you'll see that there's no subpleural sparing. All of these cysts start in the subpleural interstitium and then move more proximal, right? So the moment we see honeycombing in the setting of reticular opacities, we know that we're basically dealing with a UIP, a typical UIP or a UIP-like pattern. So reticular opacities, subpleural basal predominance, traction bronchiectasis, and nothing else. No ground glass, nodules, air trapping, etc. defines our UIP pattern. If we have honeycombing, it becomes a typical UIP pattern. If we don't have honeycombing, so it's UIP without honeycombing, then it becomes a probable UIP pattern. So the definition of UIP hasn't changed for the last 15 years. It's reticular opacities, traction bronchiectasis, subpleural basal predominance, and nothing else, right? And then we divide this in the new classification into typical or probable, depending on whether we have honeycombing or not. In the end, it doesn't matter. Both of these are UIP. One is with honeycombing, one is without honeycombing. And in both of them, in patients above the age of 60, we can make a confident diagnosis of IPF if there is no etiology, and you would not need to biopsy these patients. So here's a 72-year-old man with honeycombing. You see the reticular opacity, subpleural basal predominance, and nothing else. This is your typical UIP pattern. And if there is no etiology, it becomes IPF. This is a 57-year-old man who has reticular opacities, subpleural basal predominance, traction bronchiectasis, and nothing else. So this is a UIP pattern. This is a probable UIP pattern because we do not have honeycombing. But in a 57-year-old man, you might turn around and say, I need to know for sure that this is UIP IPF, because you know that even with the antifibrotics, your 5-year survival rate still remains between 20 and 30%. And you would not want to miss something else, especially perhaps an NSIP, which may have manifested 5 years later because of a connective tissue disease. And so you would do that. But in a patient above the age of 60 and definitely above the age of 70, this is almost always going to turn out to be an IPF, and you do not need to biopsy. So in this, you realize age matters. The older the patient, the more definitive we are about the diagnosis. So the moment we have the UIP pattern, it doesn't matter whether it's typical or probable. We look for an etiology. If the etiology is absent, it's idiopathic pulmonary fibrosis or IPF. If the etiology is present, then it is that etiology related UIP pattern. So here's a 27-year-old with honeycombing. This is a UIP pattern, but clearly in a 27-year-old, it's not going to be IPF. You can see the esophageal dilatation, and this is scleroderma ILD with a UIP pattern. This patient has pleural calcification, worked for 25 years in a brake lining factory. You see this is a probable UIP pattern, lots of traction bronchiectasis, subpleural basal predominance, no honeycombing, nothing else. So we would call this asbestos ILD with a UIP pattern. This is not IPF because it's not idiopathic, right? So that's how it works. UIP pattern, honeycombing is typical, no honeycombing is probable. Look for etiology. If you have that etiology, it is that etiology related UIP. If not, it becomes IPF. Now let's look at the other alternative. So what if we still have a fibrosing ILD, but we have other findings, or we have an age problem, or we have something that is atypical? Let's look at this, right? So this is a 46-year-old lady with dyspnea, gradually progressive over 5 years. Remember, the history also matters. Here we have honeycombing. So you'd say, guess what? This could be UIP-like. But as we go higher, we see that it's an axial distribution. So we're seeing that the pathology goes from the hilum to the periphery. We're also seeing ground glass. We're seeing air trapping. We're seeing these lucent areas here. There are some ill-defined bronchocentric nodules as well. So now we're seeing other findings, right? So we have a fibrosing ILD, but it's not subpleural basal predominant. It's axial, and all areas are equally involved. And we have other findings like ground glass, air trapping, nodules, etc. So the moment we have that, we know that this is not UIP, it is not IPF. Therefore, we call it the non-IPF or alternate diagnosis. That is your bucket here. In our country, two conditions, chronic HP and chronic sarcoid, account for 90% of all of these. And then you just have to differentiate between them. That patient was chronic HP because that's a classic presentation. This patient as well B is expiratory, A and C are inspiratory, and we can see that there are reticular opacities, traction bronchiectasis, but we then have an axial distribution, we have ground glass, we have air trapping, we have upper lobe involvement. And so this is a fibrosing ILD that is not UIP, not IPF, and therefore is chronic HP or chronic sarcoid, but this is very typical chronic HP. Here is a chronic sarcoid, 57-year-old with dyspnea, gradually progressive, where you have upper lobe distribution of the fibrosis. See the axial distribution going from the hilum to the periphery, and the lower lobes are pretty much spared. There is very little disease here. And this is a typical pattern of long-standing chronic pulmonary sarcoid. And this patient actually had a transbronchial biopsy where they showed non-caseating granulomas along with the fibrosis, and the diagnosis was proven. Here's another patient. We see traction bronchiectasis. We see some subpleural sparing. So we know that this is not UIP. And then when we look at the coronal images, we see fissural nodules. We see perivascular nodules. So we have a fibrosing ILD. It is not UIP, therefore not IPF. It's a non-IPF pattern. And between chronic HP and chronic sarcoid, when we see these perivascular and fissural nodules, we now know that we're dealing with chronic pulmonary sarcoidosis. So that's our bucket here, the last bucket, where we have a fibrosing ILD, but we have a lot of other things happening. And so we say this is an alternate diagnosis or a non-IPF etiology, and then we look between these two. It is possible that in some patients, we may need a surgical lung biopsy and or BAL to prove the diagnosis. But something has changed. So Srikanth was mentioning this. So the inbuilt trial that was first reported in September 2019 showed that if you had a non-IPF fibrosing ILD or something where you didn't really know what was going on, and it was not classic UIP IPF, nintedanib still worked. It still reduced the rate of progression of FVC. The same thing was shown by Toby Mayer's group for pirfenidone. And we have the census trial that the rheumatologists know, where in scleroderma ILD also nintedanib has shown reduction in the rate of progression of FVC. So what this means is that if you're still not able to differentiate the cause of the fibrosing ILD, so it's very important to differentiate fibrosing from non-fibrosing. But the moment we say it's fibrosing and we still can't differentiate IPF from non-IPF in a progressive fibrosing ILD, we still know that antifibrotic treatment works. And if it's not possible to biopsy, let's say in today's times, you're not going to really want to intervene in these patients. You could actually start antifibrotics and say, okay, let's see what the response is. So let's say 2 years ago, when we used to be extremely obsessive about differentiating between IPF, chronic HP, chronic sarcoid, we no longer are that obsessive about wanting to do that. Okay, what about the third bucket, indeterminate for UIP? Now, indeterminate is when it's truly indeterminate, and these patients almost always need a biopsy. So let's look at the 61-year-old with breathlessness. When we looked at this, we found reticular opacities, a little bit of traction bronchiectasis, bilateral asymmetric. There was some subpleural sparing. So we didn't know what was going on. The patient is not a smoker, does not have connective tissue disease, has no other etiologic factor, and we don't know what's going on. Is this an early UIP IPF? Is this HP? We didn't know. So this becomes indeterminate for UIP. The patient was biopsied. It turned out to be HP, was put on steroids. You can see these suture marks of where the open lung biopsy was done. And after steroids, we see that while there is some residual fibrosis with the traction bronchiectasis here, most of the ground glass is gone, right? And that was actually ground glass masquerading as a fibrosing ILD. And so that happens. We see this as well, right? Basal reticular opacities that you see here. You can see that they are subpleural, basal, but less than 5% of the lung is involved. There is no real traction bronchiectasis. There's no honeycombing. So what is this? In a 62-year-old patient without CTD and a non-smoker, what do you do with these patients, right? So 6-minute walk test is normal, PFTs are normal, DLCO is normal. It will depend upon that. If the patient is symptomatic or has abnormal PFTs, then this is classified as indeterminate and will require a biopsy. If the patient is asymptomatic or has normal PFTs, then we use the term interstitial lung abnormality or ILA. This has been described only over the last 5 years. Typically about 5% or so of the lung is involved. It's usually subclinical, very often attributed to old age. There have been some studies, but they are not very well powered, which show that if you have ILA, there is reduced survival, but we don't really know. And there are no guidelines for what to do with these. What we are doing is following them up on a yearly or a 2-yearly basis. Let's look at something interesting. This is a reverse UIP IPF. We've actually coined that phrase. And here's a 55-year-old lady with progressive breathlessness and pneumothoracis. And you see these reticular opacities, traction bronchiectasis. It's subpleural, but it's upper lobe. It's not subpleural basal, it's subpleural upper, and the upper lobes have shrunk. This is typical of pleuroparenchymal fibroelastosis. So I just threw this in because it's not uncommon. PPFE can be idiopathic or it can occur following chemotherapy or allograft stem cell transplantation. And we've seen about 7 or 8 cases now in the last 8 or 10 years. We're probably missing a few as well. So that's as far as fibrosing ILDs are concerned, right? Our aim is to differentiate IPF from non-IPF. IPF is characterized by the UIP pattern, which is reticular opacities and traction bronchiectasis, subpleural basal predominance, and nothing else. If you have honeycombing, it becomes typical. If you don't have honeycombing, it's probable, but both imply the same thing. If we have other findings, altered distribution, etc., then it's non-IPF and alternate diagnosis. And typically, it's HP sarcoid. In our country, it's almost always HP. And then there are some situations where we just don't know what's going on, in which case these people will usually require a biopsy. So what about NSIP, right? NSIP can be both fibrosing and non-fibrosing. It's commonly seen with connective tissue diseases. It may precede a full-blown CTD by a few years, but remember that idiopathic NSIP is extremely rare. So yesterday, I did a Quizinar, that is an ILD webinar, but it was only quizzes. And the only question that kept being asked is, how do you differentiate fibrosing NSIP from UIP? Well, you don't. Idiopathic fibrosing NSIP is an extremely, extremely, extremely rare condition. And so everything is to be assumed to be UIP IPF unless the patient is below the age of 50, in which case the patient will require a biopsy if there is no connective tissue disease. And most likely this patient will turn out to have connective tissue disease in the future. So just if we understand this, we will not make mistakes, right? That's the important thing. And all NSIP is almost always bilaterally symmetrical, has a combination of ground glass and reticular opacities and subpleural sparing. So that's a 34-year-old with NSIP. And what is subpleural sparing? Here is a UIP and the subpleural interstitium is involved. Here is NSIP and the subpleural, there's a little thin rim here of sparing that you see, which is also better appreciated on the sagittal images. No sparing and sparing. This is a 22-year-old with Raynaud's, very early reticular opacities, but with subpleural sparing. And this is an early NSIP pattern as well. Now, another thing we've started seeing is post-COVID fibrosis. This patient was positive in April, still has dyspnea, still has exertional dyspnea mainly. And these are the residual changes that we are now seeing. How much of this is actually fibrosis? How much is ground glass? How much is reversible? How much is irreversible? We don't have answers. Right now, a lot of these patients are being given antifibrotics by the pulmonary physicians, I think all over the country now. And we are recommending a follow-up study at 3 months to differentiate reversible from irreversible changes. We're also quantifying them using caliper to see if we can help in the future. We don't have answers, but perhaps later we will. So reminder, at the end of this meeting, in about 20 minutes, I'm running a quiz. please go to this URL, paulev.com/refcafe-rentgen. I know you will have to type this in properly, but if you do, you should be able to see. We're going to run 10 quizzes and find out who the winner is at the end, right? So now let's look at non-fibrosing ILDs characterized by those signs, and we'll run through all the signs as well. The commonest is ground glass attenuation, which is increased attenuation that does not obscure the underlying vessels, and you often have spared areas as well. Now, this is a completely non-specific sign. And the same appearance can mean multiple things depending upon the presentation, which is why for radiologists as well, the history is so important. And for physicians, when you refer cases, you should at least tell us whether the patient is a smoker, non-smoker, has underlying disease, acute, chronic, etc. So if the same patient has a subacute presentation as a non-smoker exposed to pigeons, then it's HP. The same patient smoker, then it's DIP or severe RBILD. The same patient presenting acutely is AIP. And in today's context, this is also characteristic of COVID pneumonia. And the same patient is HIV positive. We will talk of PCP, PJP, right? Same appearance means different things depending upon the presentation. Now, if you have ground glass associated with other findings, so we call it ground glass plus, then we may be better off. So here we see ground glass, but we see a lot of air trapping on the expiratory images, in which case we might say that this is suggestive of HP. Now, if we have the head cheese sign, which is ground glass, some normal areas, some areas of increased lucency. So this on the expiratory study would be air trapping. Then when you have three things happening at the same time, we call it the head cheese sign. And the head cheese sign is very specific for chronic HP. And head cheese has nothing to do with cheese. It's actually a combination of multiple meats that are packed together. So it looks variegated and heterogeneous like this. It's not very sensitive, but it's specific, which means that if you have 100 patients of chronic HP, in about 50 of them, this sign will be there, and 50 of them, it will not be there. But if 100 patients present with this sign, 93 of them will turn out to have chronic HP. It's the same thing as using CT for COVID-19 diagnosis. I think this is something that has become very prevalent across the country. But remember that the sensitivity of CT for picking up COVID-19 in a PCR positive patient is only 35 to 50%, but it's specific. Once you see those typical findings in a patient with acute fever, etc., then that's almost suggestive of COVID-19. Then you can have ground glass plus consolidation. So when you see that combination, that's the organizing pneumonia pattern. Remember, the OP pattern can be idiopathic or cryptogenic when we call it COP, or it can be due to other etiologies. It could be drug-induced connective tissue disease, in today's day, COVID-19, in which case it is that etiology-related OP. So that's why we use the term OP and not COP. So this is peribronchovascular ground glass and consolidation. This is subpleural basal consolidation with some ground glass at the periphery. This is the so-called reverse ground glass or atoll sign, where you have ground glass in the center and consolidation at the periphery. And again, you have this reverse bat swings appearance, but you have ground glass here and consolidation. This is also seen with eosinophilic pneumonias. Remember, eosinophilic pneumonias are again organizing pneumonias with raised eosinophil count. So same spectrum that we're looking at. This is now COVID pneumonia with different forms of OP patterns, but they're all organizing pneumonia patterns as well. Then we have ground glass plus septal thickening. So when you see that, it gives rise to this crazy paving pattern, and you see this with alveolar proteinosis. And again, patients with COVID-19 have these focal areas of ground glass plus septal thickening. We get this crazy paving pattern as well in these patients too. Then let's move on to septal thickening. So we've looked at ground glass, we've looked at ground glass and consolidation. Now we look at septal thickening. So here is a patient who has septal thickening, upper lobe predominance, a little bit of perihilar ground glass and bilateral pleural effusions. And so clearly this is different, and this is what we would get with cardiogenic pulmonary edema. This patient was put on diuretics and actually came back 36 hours later at my request, and we showed that everything's gone away. Also remember that this is the first time in the last 34 minutes that I have shown Pleural effusions, right? Pleural effusions and interstitial lung diseases don't go hand in hand. Typically, if you have pleural effusions, then it's pulmonary edema. It could be malignancy with lymphangitis. It could be serositis in a connective tissue disease, or it's a superadded complication like tuberculosis, etc. So remember, be very, very careful when we have pleural effusions in a setting of interstitial lung diseases. Now, when we have septal thickening like this, which is asymmetric, in a patient who has a known malignancy, then we're obviously dealing with lymphangitis. One more rule here: in your lifetime or in anybody's lifetime, to see lymphangitis as the first presentation of any malignancy is extremely, extremely rare. So this is more for radiologists. We tell them never to diagnose lymphangitis unless you know that the patient has a known primary. So in non-fibrosing ILDs, we've looked at ground glass, consolidation, septal thickening. Now let's look at nodules. And nodules can be ill-defined or discrete. If you have ill-defined bronchocentric or centrilobular nodules like we see here, then this is very characteristic of, I think somebody else is drawing lines on my slides. I wonder who that is and why they're doing this. But nevertheless, that should be fine. It's not otherwise distracting. So these ill-defined bronchocentric nodules that we see here are very characteristic of hypersensitivity pneumonitis, as long as a patient is not a smoker, right? In a smoker, the same appearance would occur with desquamative interstitial pneumonitis. And I'm blowing this up to show you these ill-defined bronchocentric nodules. Remember, HP is an airway disease. It becomes interstitial as we move on, but it starts as an airway disease, and that's why you see these ill-defined bronchocentric nodules as an immune response. Now, if you have expiratory images, you'll also see these areas of increased lucency because of air trapping that occurs because these nodules plug the bronchioles and produce this kind of air trapping. And then you have discrete nodules. So when you have these discrete nodules with a perivascular, subpleural, perihilar, fissural distribution, then this is typical of sarcoid, and you can see this perivascular nodularity extremely well. Remember, and I did say that coronal sagittal images are important. Sagittal images we already saw helped us with those UIP patterns and subpleural sparing, etc. And you can see this here as well, that the fissural nodules are better appreciated on the coronal images in this patient with sarcoid. Then we have other discrete nodular diseases, 2 to 3 millimeter size randomly distributed nodules that we get with miliary, clustered focal nodules like these. These are denser. This is infectious bronchiolitis that we see with TB. And the nodules of varying sizes, confluent with eggshell lymph nodal calcification, then this becomes silicosis. So I have a small table that I've made. Ill-defined bronchocentric nodules, diffuse would be HP, and you can add here patchy would be tropical eosinophilia. And then this is how your discrete nodules work out as well. So this typically would take care of about 95% of all nodular diseases that you would see within the lung. So reminder again, we're running a quiz at the end, and this is the URL. You will need another device, or on the same device, I will be showing the images as part of the quiz, so we can look at that. At the end, we have cystic lung diseases. I told you they are not interstitial lung diseases. They may be associated, but 4 conditions: lymphangioliomyomatosis, pulmonary Langerhans cell histiocytosis, Birt-Hogg-Dubé syndrome, which is not uncommon, and lymphocytic interstitial pneumonia. LIP would be responsible for 90 to 95% of all cystic lung diseases that we see. If the patient is a woman in the reproductive age group, presents with a pneumothorax, then it's almost always lymphangioliomyomatosis. If you're not sure, you can do the serum VGEF levels, and if they are high, you have your diagnosis. So you don't have to biopsy these patients anymore. If the patient is a smoker, then it's almost always Langerhans cell histiocytosis. Remember, you don't make a diagnosis of PLCH in a non-smoker. Again, you can get LAM in a man, but only when the patient has tuberous sclerosis, which is a neurocutaneous syndrome. Similarly, the only time you get PLCH, cystic disease, in a non-smoker is when you have systemic histiocytic diseases like Lederer, Sive, Hanschula, Christian, than Chester or one of those other sinus histiocytic diseases. But if it's only lung, then it predominantly occurs in smokers. So what I tell the radiologist is that a non-smoker never make a diagnosis of PLCH. BHT can occur in a man or a woman, but the intervening lung is absolutely normal. As we move towards the lower lobes, the cysts become larger, lenticular shaped, and you can see these lenticular shaped cysts here as well. And often you see these vessels which seem to be traversing through the cysts. The moment we see incidental cysts, typically we see them when we're doing PET CTs in patients with renal cell carcinoma, CA colon, CA pancreas, because they are associated. And that's how we started diagnosing these. Or you have pneumothoraces and just cysts, and the patient is a non-smoker, or a man who's a non-smoker, and that's how you start making the diagnosis as well, right? So that's how it happens. Again, we've got somebody who's drawing lines here, and I wonder who that person is. Anyway, so that's what happens. And here is a patient with LIP. Basically, we get cysts with a perivascular, as you can see them here, in a patient who have Sjogren's disease or some other connective tissue disease. And then basically, you see a little bit of ground glass and things like that. So clearly somebody is vandalizing here. I thought all of this had stopped over a period of time. But whoever's doing this, we really need to find out and boot this person out, and is obviously creating a lot of
I would
problems.
request whoever is annotating, please stop annotating on the
Not
screen.
annotating. This person is behaving badly and doing this on purpose. So that's
Yeah.
essentially what it is. Nobody would annotate with scribbles like this anyway. So whoever you are, you're literally a dipshit doing this. I'm sorry to use the word, but you're unnecessarily creating a problem here, and you really don't deserve to be here. All right. So for everybody else who can see this, we basically have a flow chart that I will run through. Right. So if you have diffuse lung diseases, if you have reticular opacities and traction bronchiectasis, that would define a fibrosing ILD. If you have ground glass, nodules, mosaic, septal thickening, that's a non-fibrosing ILD. So that's the first thing that we would basically do. And if it's a non-fibrosing ILD, then you would have different patterns that we've already discussed that we would look at to come to a diagnosis. Now, if you have a fibrosing ILD, you would check if it's with or without honeycombing, subpleural basal predominant, and nothing else. And if you have this combination, then you know you're dealing with a UIP IPF pattern. It's IPF if there's no etiology and the patient is above 60. If you have connective tissue disease, asbestosis, etc., then it's that etiology related UIP pattern. Now, if you have ground glass nodules, mosaic, upper mid-zone predominance, then it's non-IPF, and you have to differentiate between chronic HP and chronic sarcoid. So this book is available on Amazon, both as a Kindle edition as well as hard copy. You can search for this, just type it in or type my name, and you can purchase it if you want. So we're going to run this quiz now. And if all of you can go to this paulev.com/ref cafe Rentgen, then I can start the quiz. It's a rapid fire 10 quiz. And if you've registered with your name, we'll also know who is first, second, third, etc. If on the chat, couple of people can tell me that they're able to do this, then we can start. So basically now the quiz is on.
The link is already in the chat. I hope the participants have seen the link and they can visit the link as requested by Dr. Bhavin.
So there's no prize unless Sun Pharma wants to do that. But basically it's called the ILD quiz competition. And this is the slide you should be able to see. And we'll know once we look at the presentation as to what's happening. All right. So, and remember that you will see everything at that site, whatever you're seeing here. So even with all these scribbles that we have, I don't think it should be a problem. So here's the first question. This is a 70-year-old man with gradually progressive dyspnea. And here is what you should be seeing. Great. I can see that some people, this is a 30-second timer. And if you can just let me know whether it's IPF, non-IPF, NSIP, or PPFE. I have only 11 people who are, okay, now 13. There's 11 seconds to go. More people, it'd be nice if more people participate because that really helps, right? Okay, so we're done and we will move on. So the correct answer was IPF. All of y'all got that right. That's very nice. And that's the leaderboard where Ashutosh Mishra is first. Of course, all of these actually are first, but the person who does it the fastest gets to be number one on the leaderboard. All right, let's move on to the second question. This is a 68-year-old man with progressive breathlessness. I have another device where I can see it, so I know that it's working well. And here is your question. So we have an axial image, we have a sagittal image here, and you can see that it's a fibrosing ILD, but it's different from the earlier one. And you still need to tell me whether it's IPF, non-IPF, NSIP, or PPFE. I can see only, yeah, so now there are 7 seconds left. Come on, guys. I have only 10, 11 people, 12 people have answered. Okay, let's look at what we had. So 42% of you got it right. That is about a little less than half. And this is the leaderboard at this point in time. Do remember that we saw reticular opacities, we saw subpleural basal predominance and nothing else. So it was UIP without honeycombing. So that also implies that this is IPF. All right. 34-year-old lady with progressive breathlessness. And again, you need to tell me whether it's IPF, non-IPF, NSIP, or PPFE. So you see the reticular opacities. There isn't much traction bronchiectasis, but there's a very specific sign here, which I've already talked about, which should help us figure out which one of these it is. All right. So about 12 seconds left. Please do answer. I guess we have about 13 or 14 people who are tackling this, which is great. I think it's a good way to go. Maybe Sun Pharma can decide eventually to figure out if they want to give a prize. So here's NSIP with 73%, which is perfect. We had classic subpleural sparing, and you can see that here as well. And Ashutosh is still in the lead, and Mubin is second, and that's pretty much the leaderboard that we have. All right. 47-year-old woman with a 10 years history of mildly progressive dyspnea, and you can see this here. All right. So I've actually shown this case, if you remember it. We have a fibrosing ILD, we have honeycombing here as well, but then you have the rest of the images. That's 2 axial images and a sagittal image that should help. Remember that the leaderboard works not only on getting it right, but also on speed. So we have 6 seconds left. We have 16 results. That's the highest so far that we're getting. 17, 18, very nice. 20, 21. Oh, great. And so the answer is non-IPF. This is chronic HP. A little under half of you got it right. So remember, so for those of you calling it NSIP, remember NSIP should be bilateral symmetric. With subpleural sparing, preferably in a patient who has connective tissue disease. PPFE is an upper lobe disease, so clearly that's not what we should have been looking at. But we saw fibrosing ILD, we saw honeycombing, we saw traction bronchiectasis, but then we saw axial distribution, ground glass, so many other things. So that tells us it's non-IPF and therefore chronic HP. And so we have the same leaderboard that's continuing with Ashutosh, Mobin, Amal, Nagrajan. This is good fun. And we move on to the last one. Now, this is a kind of question where everybody should get this right. 55-year-old lady, 2 years history of breathlessness with pneumothoraces. I've shown this image and it's the same 4. And clearly now everybody should get this, right? It should be what we call 100% coming in here. So let me know if this works for you, right? So we've got 13, 14, we've got 10 seconds left, 17, 18, 20, come on, 5 seconds left, any more? Last time we had 21 people answering. Okay, so 20 people have answered, and let's see what we have here. So remember, it's upper lobe disease, subpleural upper lobe predominance, and shrinkage of the upper lobe. So the answer is PPFE. 80% if you got it right. It is obviously non-IPF, but the answer is PPFE. And I'd actually shown this earlier as well. And we see Mobeen, Amal, Nagarajan, Romit, and Dakshinamurthy, who are the first 6. Let's move on. Nashutosh is obviously first. All right, sixth question, 20-year-old man with 2 months history of dyspnea. Now we are moving to non-fibrosing ILDs. We have 2 axial images. You have 25 seconds left, and we've changed the entire set of differentials with sarcoid, HP, organizing pneumonia, and alveolar proteinosis. 15 seconds left. That's the axial set. You can see it on your device at PolEV as well. Very classic appearance that we see here. And 22 people have answered. All right, so you see these ill-defined bronchocentric nodules here. And as I said, once you have ill-defined bronchocentric nodules in a non-smoker, your diagnosis would be hypersensitivity pneumonitis. So 73% of you got it right. That's brilliant. And the leaderboard, and Amal has overtaken Ashutosh. Brilliant. And Nagarajan and Mobeen are third and fourth. This is good fun. And let's move on. So 38-year-old man with 3 months history of dyspnea here. And here it's loading. And again, you have an axial image, a coronal image. You have one of these 4 that you need to look at. It could be sarcoid, HP, pneumonia, or alveolar proteinosis, but very, very typical appearance that we have here. And let's see who we're getting. 17 people, 9 seconds left, 19, 7 seconds left. 1 more second, and we have 24 results. That's the highest we've had so far. And we see nodules, we see perivascular nodules, we see fissural nodules, discrete nodules, and that's characteristic of sarcoid. So the answer was sarcoid. 80% of you got this right. That's the highest we've had. No, well, the highest was with PPFE. But otherwise, that's a good score for everyone. And that's sarcoid. And again, we have Amal, who's actually leading literally by 14 points as far as Ashutosh is concerned. And the Nagarajan is third, and literally the difference is so less among the 3 of them. So let's see where we get here. 41-year-old man, 5 weeks history of fever, breathlessness, and Velcro rals. The history can give you the diagnosis as well. And we have an axial and a coronal here. And you have a very typical appearance again. Okay, 22 seconds, 10 people. Remember, speed and accuracy. This tests both. And the faster you are, the better it is. And now we have 10 seconds left. So people are warming up now, right, as to the entire way in which this works. And we have 24 people. I think that's the maximum. Oh, 25 people. That's the highest we've had so far. We have consolidation. It's peribronchovascular and subpleural consolidation. The only interstitial lung disease that presents with consolidation is organizing pneumonia. And so that's the answer here. 92% of you got it right. That is so cool. That's the highest so far that we have had of you as a group. And it's heartwarming to me because it means that, you know, my lecture is a success, if nothing else. And let's see the leaderboard here. It's still Amal. And but the difference between Amal, Ashutosh, Nagarajan is literally, so, you know, now it's literally fastest finger first for the next 2 to see if Ashutosh can overtake Amal, or if Nagarajan can leapfrog, or if Dakshinamurthy can actually move further ahead as well or not. So 16-year-old woman with subacute onset progressive dyspnea, and this is what we have. It's a very classic appearance on the axial and the coronal scans. You should be able to get this answer, right? And it all really depends on who was the one who got this first. It's, again, I expect that we should have a 95% correctness here. Also, this is 9 seconds left. 7, and 25 people have already answered. So everyone's moving literally quickly here. And we have 27 people who've answered. So crazy paving appearance, isn't it? Ground glass with septal thickening. So the moment we have crazy paving diffuse, the only condition here that would show this is alveolar proteinosis, and 93%. So now that's the highest so far, right? And 4% is literally one person, I guess, here. And that's the leaderboard again. So Amal's still leading, Ashutosh second, Nagarajan is third. And here's the last question. It's on cystic lung disease. And this is a 45-year-old man, non-smoker with repeated pneumothoraces. These are the axial images, 2009, 2010, 2011, 13, 14, 15. No specific change, very typical appearance. You see the history as well here. 45-year-old man, non-smoker, repeated pneumothoraces. What is your answer here? Right? So 8 seconds, 22, 6 seconds, 23, 2 more seconds left, 25, and we end with 25. All right, lenticular shaped cysts. So first of all, man, so not lamb, non-smoker, so not PLCH. I did not mention the patient has connective tissue diseases, so it's not LIP. So by default, it's BHD, but look at these lenticular shaped cysts. In fact, this patient in 2009, we were not diagnosing BHD. It all happened in 2015 when this patient decided to go scuba diving in Hawaii. True story, right? Mad Gujarati, very rich, develops a pneumothorax at that time, is flown to San Francisco, goes to UCSF, they do a biopsy and they find that this is BHD. Then they did the folliculin gene and they confirmed that it was BHD. So this was our second patient. The first one also had a very convoluted history, which involved Canada and cousins and pneumothoraces, etc. But once we got a sense that BHD also can occur in Indians, we've started picking up more and more of these. And the simplest is to do the folliculin gene study. All right. I know you're all eager to see 65% if you got this. So please remember the history. LAM cannot occur unless you have tuberous sclerosis in a man, and you cannot get a PLCH in a non-smoker, right? So that's how you should remember. And the winner, oh, so Nagarajan leapfrog. Remember, he was third. And clearly, this is so amazing, right? So Dr. Nagarajan, I don't know you, but you're first. Amal is second. Ashutosh, who was leading for 6 questions or 5 questions, is third. And Dakshinamurti is fourth. Sun Pharma, guys, you can take a screenshot of this. And if you want to give a prize or something, I mean, you can go ahead and do that. Maybe you can take copies of my book from me and then give it to them, whatever it is. I mean, think about what you would like to do with this, right? And thank you for your attention.
Thank you, Dr. Bhavin. That was as wonderful as ever. I think you very beautifully highlighted the important points, starting right from the importance of a good quality scan and then differentiating IPF, non-IPF, when to do biopsy. And I really enjoyed, like the emphasis you give on traction bronchiectasis and how we need to interpret that in a practice. So it's very, and the quiz, I think, was exciting. It was like a T20 match. It was really exciting. And congratulations to the Dr. Nagaraj who won this. And
Srikanth, I must mention Dr. Amal and Dakshinamurti are my postgraduates.
Congrats to them. Good. So,
Bhavin.
Dr. Bhavin?
Yeah, Bhavin, can you hear me?
Yeah, I can.
These Amal Johnson and Dakshinamurti are my postgraduates in my fellow.
How nice that
Respiratory.
Very good.
Very good.
Yeah.
Very good.
Very happy with all of this.
Congratulations, Amal and Dakshinamurti.
Yeah. So you should give them some prize or something, right?
Yeah, I think, through our foundation, we will honor them. Yeah, definitely. I think you have given this book you have ordered.
And Dr. Nagarajan should get a prize from somebody.
Where is he from, Dr. Nagaraj? Can you type it in your chat thing? Are you from MMC ITM?
Which college are you from, Nagaraj?
I guess he can get back, because if he was doing it through YouTube, then he may not
Yeah.
be in.
Oh, okay.
Okay.
Oh, here
No,
he
but
is.
he's here. Yeah, I think I can see him here.
Yeah,
Yeah,
he's there.
Dr.
He
Nagaraj, where are you
answered in
from?
the chat box as well, so he can. So I guess somebody can get
Kaveri
him.
Hospital.
Kaveri Hospital. Dr. Nagarajan is from
Okay.
Kaveri.
Kaveri Hospital. Okay, right.
Okay.
Yeah, we'll
Uh,
open up for
where
questions
is
if there are
Kaveri?
any.
Is it in Chennai or Trichy?
Yeah,
Trichy.
Chennai.
Kaveri Hospital. Chennai. I don't know where he is
Trichy.
from.
Trichy. Yeah.
Okay.
He's from Trichy. Okay.
I know there's a Kaveri in Trichy, so yeah. All right, let's
We have
move.
received a couple
Yeah,
of questions.
Ajay will go ahead with the questions. Dr. Ajay, go
Yeah.
ahead.
Dr. Amal has asked, what is the criteria for radiological progression in PFILD? How to quantitate fibrosis in HRCT?
So we are now using Caliper as a standard quantifying tool. If you don't have that, then it would be visual. And so then you would basically check, you would put two scans together on the workstation and then see if there is progression of honeycombing or traction bronchiectasis or reticular opacities, etc. But more and more it is relying on Caliper as a quantifying tool.
Okay. Amal, I hope you got that. Thank you, sir, for the answer. There's one more question. Is chronic HP, hypersensitive pneumonitis, upper lobe predominant?
Not necessary. Chronic sarcoid is often upper lobe predominant. The thing with chronic HP is that you don't have a subpleural basal predominance the way IPF has. So you would have an axial distribution. You can have upper lobe predominance, but it's usually diffusely, the lung is diffusely involved. What you do see in the upper lobes is a very interesting form of fibrosis, which is bronchocentric fibrosis. So you get upper lobe bronchocentric fibrosis, which is reasonably characteristic of chronic HP.
Dr. Srikanth, these are the questions that have come in the chat. As
Okay.
of now, we don't have any more
Have a
questions.
look at if there are more questions, maybe we can take it up later. Bhavin, thanks. And I just have one comment and your response to this. See, as somebody who has been observing IPF in particular over the last so many years, so we, as I said in my earlier introduction, before pirfenidone and nintedanib, we had trials where we basically look at FVC, forced vital capacity, and the rate of decline of FVC. And that quantum was taken as a primary endpoint. Now that we have two antifibrotic drugs, any further new drug which has to be researched may need an additional endpoint, because FEC, the quantum which I would expect in the next new drug, whichever comes, will be a little less than what it would be for a treatment-naive patient. So do you think HRCT could be an additional endpoint in following up these kinds of patients, especially with a particular reference to trials?
Yeah. So what they are doing now is looking at, so there have been enough papers that have shown, okay, somebody wants me to start my video. So maybe
Yeah, I only asked you to start.
yeah,
Start
I'll
the
just
video.
do that for a minute. So what happens is HRCT per se is difficult as an endpoint, because unless you can quantify, it becomes a challenge. Now, what we have seen, and there have been a bunch of papers that came out where they have looked at follow-up CT with quantification with caliper, and then compared that to FVC decline and then eventual patient outcome to see whether change in FVC can be taken over by quantification software in CT. So they've shown that it works. And not just caliper, there are other forms of texture analysis softwares, and most of them work well when compared to FVCs or change in FVC. So it is likely that going ahead, you would have trials that would use quantification changes to look at what's happening. And when you do that, you can actually reduce the number of patients as well, which reduces the cost of a trial too. So we can hope in the future that we will have a CT with quantification in drug trials for IPF.
That's very interesting, Bhavin. Thanks again for your wonderful lecture. And we now move on to the next topic of the day, a very, very interesting topic. And it's my pleasure to introduce Dr. R.Narasimhan, Senior Respiratory Physician, Apollo Hospitals, Chennai, is the Chairman of Respiratory Research Foundation of India. Dr. Narasimhan graduated from and postgraduated from SV Medical College, Tirupati. His entire career has been brilliant. He's been the topper in the college education. He's been trained in intervention pulmonology and lung transplantation in Pittsburgh. He's also a fellow of Royal College of Physicians of Edinburgh and Glasgow, and also the governor of American College of Chest Physicians of South India. Dr. Narasimhan has also been responsible for initiating EBA services in Apollo and is also credited for having started the narrowband imaging bronchoscope for the first time in Apollo. Dr. Narasimhan is also the editorial board of Lung India, Chest, Indian Journal of Sleep, and is also a reviewer for many of the peer-reviewed journals. Dr. Narasimhan has authored textbooks in asthma, sleep-related disease, and intervention pulmonology, has more than 45 publications to his credit. He's a visiting professor from University of Queensland. And personally, he has been very, very popular in the academic field throughout the country, giving lectures all over the place. And I have been part of many of his programs, and I have fond memories of our early days when Dr. Narasimhan organized ACCP programs, and I was one of the speakers, and our relationship to me on a personal note goes a very, very long, so many years back. He's also the chairman, I told you, of the Respiratory Research Foundation of India. And I also realized that he's a cricketer and a table tennis player. Maybe I'm also a table tennis player. Maybe one of these days we should have a one-to-one match. So I'm quite keen. I'm waiting for that. And he has also been involved in a lot of social activities like creating awareness talks in asthma, smoking, and tuberculosis. And I think he's a very regular writer in the Hindu, which all of us follow it regularly, and one of the most weighted columns in Hindu. So with this introduction, I now call upon Dr. Narasimhan to give his talk on the treatment strategy of idiopathic pulmonary fibrosis.
Yeah. Thank you, Dr. Srikanth.
Before we go on, there's one more person who got the third prize, Dr. Ashutosh Mishra from Apollo DNB, Indraprastha Hospital. He's in second. Wow. He got the third prize. So I just wanted to make a mention because I think we were not able to see his name at that time. I just got the screenshot from Chandrasekhar.
All right. Okay, thank you, Dr. Srikanth, for that nice introduction. I also have some fond memories. I also would like to play table tennis with you. I think it's now it will become popular because indoor games are going to become popular now. It is one of the games which people never used to. Slowly it went out of vogue. Now the chess, table tennis, all these things will come back into the vogue. And coming back to our topic, I'm going to talk on the goals of IPF therapy. It's not a very exciting topic like Bhavin Jankharia's. We are looking at the CT scan and thinking of differential diagnosis, discussing differential diagnosis is an entirely interesting thing. But when you have a patient in front of you in whom you have made a diagnosis of IPF, or where the radiologist has told you that it is interstitial pulmonary fibrosis, it's a devastating disease, and you are going to break the news to the patient that he might not live longer, maybe 3 years, 4 years, or 5 years. So what are the goals of this therapy? The goals of IPF therapy is a reduction in mortality and best a reduction in exacerbations. And I must tell you, diagnosing and managing IPF is a rapidly evolving subspecialty. With so many diagnoses, we had actually the criteria of diagnosis have been changed so many times, and the radiological classifications have been so many times, and the treatment guidelines and treatment, I think the latest one is published, of which we are part of it, has been published in Lung India. There has been so much of changes. So at best, our idea is to see and identify the group that would respond to the treatment, and also identify the group which should not be given steroids, and what are the drugs that cannot be given. So my agenda of the talk will be on to that. I'll be talking about the two wonderful drugs that have come into the market for treating the interstitial pulmonary fibrosis. And as I said, we also should know whether which drug should not be given, and also to plan them for a lung transplantation. As I said, there is an attempt, a constant attempt to identify different IPF subtypes. You have an interstitial lung disease, ILD, and IPF. So if you make a non-IPF ILD, we keep telling the patient that the prognosis is relatively good. But in IPF itself, we have found in some of the studies, in some of the placebo arms, there isn't a great difference between the placebo arm and the treated arm. Actually, there are certain subphenotypes, in other words, the endotypes, which play some part, and there is an attempt to identifying them. So if you had asked me some 15 years back, most of the patients would have been started on treatment for tuberculosis because we had no access to bronchoscopes, we had no access to lung biopsies. Now there's so much of change. We do bronchoscopies, we do biopsies, we do cryobiopsies, we have wax biopsies. So it's quite possible to subtype them. And also a lot of markers are identified in bronchorolavage. So maybe 10 years down the line, there might be a better kind of treatment, and there will be more personal treatment for interstitial pulmonary fibrosis too. And this explains, as I said, the different responses in the treatment in the placebo arm. There is an attempt to use or identify genetic and molecular biomarkers for use of these drugs. It's important. I think there will be some newer drugs that will come into the market, which I will be showing in some of my slides. And you need to have some kind of a marker by which you can identify this particular patient would respond to this. Until this novel therapies emerge, that halt is a very big ask in IPF treatment. Or reverse fibrosis, again a very difficult task. And restore the lung architecture to normal, very, very difficult. The goal will be to slow the fibrosis and plan for a lung transplantation. And that will be the goal. You can either slow the fibrosis or come down on exacerbations and also plan the patient for a lung transplant. That's our goal of treatment. So how do we achieve this goal? This can be achieved by pharmacologic therapy, the most important part of the management of IPF, and pulmonary rehabilitation and oxygen therapy, managing the comorbidities, and also suggesting about the lung transplantation. My advice to most of my postgraduates is the day you make a diagnosis of IPF, you must put the seed of lung transplantation in the patient's mind. Only then we can make the transplantation popular and patients will start accepting transplantation as one of the means of getting ready for a transplant or getting ready for treatment. We do have quite an acceptance nowadays for a transplant because IPF many people know about it. So that seed has to be put on day one, symptom management and palliative and advanced care. My agenda today will be, I will be spending some time on pharmacologic therapy and also some time on lung transplantation. The rest of it I will not be discussing today. The perfidobin is one of the new antifibrotic drugs. It inhibits experimental lung, heart, liver, and kidney fibrosis. It reduces in vitro fibroblast growth factors and also inhibits a number of cytokines important in pulmonary fibrosis. It regulates the human lung fibrosis proliferation and transforming beta growth factor mediated differentiation into myofibroblasts. I'll be talking about this myofibroblasts and fibrogenic activity in most of my slides, wherever I'm touching upon the biologicals or upon the dynamics, because that is the treatment and most of the future research is going towards the myofibroblast. We know what actually happens is starts as a septal thickening, then it becomes fibrosis, then the fibrosis results in myofibroblast number increasing, and they proliferate and become a honeycomb in the lung. See, the whole attempt is directed towards this direction only, to identify the myofibroblast maturation and also to come down and also reduce the myofibroblast proliferation. If we can do that, we can reduce the fibrosis and the scarring tissue. So how is it available? It's available as 267 milligram capsules, 3 capsules, 3 times a day. It has to be given with meals. It can cause severe stomach upsets. You can space them in the meals. And photosensitivity rash can occur, and one should be prepared for that. And also, of course, hepatotoxicity. You need to have a regular blood work and also check the liver function tests on a regular basis. So once Petrodone came into the market, there were a couple of open-ended trials done in, especially first it came in Japan. They came out with a lot of trials about the role of Petrodone, both use and non-use of this. And Professor Raghu was the one who was initially involved in the studies, and even now he continues to be in the forefront in trying to find guidelines on this interstitial pulmonary fibrosis. After that, came across two pivotal international multi-center randomized controlled trials, the capacity 004 and 006. The capacity trials were into two because in the first capacity trial, the perfluridone was started in a slightly lower dosage, and in the capacity 2, the second 006, it was started with a higher dosage. So, which means the capacity 004 had a placebo arm, an arm which contained perfluridone in a lower dosage, and an arm which had perfluridone in 3 capsules 3 times a dosage. And the same thing was continued as the next 006 trial. So it was all cases with mild to moderate IPF. So they are defined as an FVC of more than 50. We rarely see our ILD patients at this level. Most of our ILD patients have an FVC of less than 50 or 40. Most when I happen to see them, only in the last 1.5 years we're able to see FVCs at a slight IPF patient with a slightly better IPF, where I can think of transplant or I can think of some drugs, or the predicted DLCO of more than 35%. The study period was a fairly long period, was done for a period of 72 weeks. And the pooled data, it was pooled because the inclusion criteria of both capacity 004 and 006 were more or less the same. The pooled data showed some benefit with high dose in terms of mortality. And on the basis of this, the European Medical Agency approved its use in 2011 in Europe. It first came into the market in Europe, and after that it spread across. But United States of America did not agree to this. The FDA wanted one more study because the capacity trial had two trials, 004 and 006, and the pooled trial data only was given. So they wanted to actually see how effective is it. So after the initial screening in the ASCENT study, they divided them into placebo and the perfluridone, and the placebo group had 278 patients, and perfluridone was administered to 277 patients. The primary outcome was the percentage of FVC change from baseline to week 52 weeks. And the secondary outcomes was change in 6-minute walk distance from baseline to 52. The secondary endpoints, progression-free survival, all-cause mortality, and treatment emergent mortality. In that, they compared both capacity and ASCENT, because ASCENT trial, the criteria was more or less like capacity. So both were compared together, and the emergent mortality was. So if you look into that, this first panel, if you look into this thing, the decreased FVC or death, if you compare and see, the perfluridone group definitely performed much better than the placebo group at the end of the 52nd week. And similarly, the change in FVC also, if you compare and see, the placebo group had a rapid decline in FVC as the days progressed, whereas the patients with perfluridone had a better sustenance of FVC, though the report that the decline was not that much. And if you look at the secondary outcomes, like decreased walk distance, something the perfluridone group was definitely much better than the placebo group. And same was the case with regards to progression survival. So the four important factors, like the decreased FVC, the progression-free survival, and decreased distance with testing, and also the changes in FVC were quite favorable in terms of FVC. So it was accepted by the FDA, and it was used across the world. Most of the centers started going to costly drug at the time. And if you look into the mortality data of the ASCENT trial, the number of patients in the ASCENT trial was perfluridone, we had about 278. And if you look at the death rate, the all-cause mortality was around 11. And if you look at the placebo arm, there were 20, almost double the all-cause mortality. Similarly, was a idiopathic pulmonary fibrosis. The perfluridone group had a 1% mortality, whereas the placebo group had almost a double, 2.5% mortality. And the pooled data also showed similar results. The death rate was around pirfenidone in pirfenidone group, it was about 3.5%, whereas in placebo arm it was 6.7, the all-cause mortality. And related to IPF was only 1% in pirfenidone. So it was so favorable, the results were so favorable. IPF was allowed as a drug for IPF. It slows the rate of progression. Fewer patients taking pirfenidone died during the trials compared to those taking the placebo. The dosing was 267 milligram capsules taken 3 times per day with meals. The side effects can be managed by reducing the dose of pirfenidone. There was no need to stop the drugs. So having seen the success of this pirfenidone, the recap study, they just continued the capacity trial after 5 years of the continued. Patients demonstrated no major problems or side effects as the study was continued, proving home the point that pirfenidone can be given for a long in patients in whom the response was good. It can be continued for a fairly long period. And at 5 years, approximately 50% of the cohorts remained alive. Again, a very good thing. It was no longer a disease which had a devastating mortality and a depressing news that we had to break to the patient, because we have now drugs which you can tell the patient that these drugs can be given to make the patient's quality of life is slightly better, though they are not curative. Another observation was most serious side effects appeared within the first 6 months. And 6 months we had, if you don't have any problem, that's the reason most of the time we tell the patients to follow up with a hepatitis, liver function test. Every month I tell them to follow it up. And if within 6 months they're quite comfortable, we tell them not to do it as a routine basis, but after 3 or 4 months they can repeat it. None of the serious effects, side effects are serious enough to warrant stopping the drug. And now let's shift gears and go on to another interesting drug, nintedanib. These 2 drugs are the ones which are revolutionized the management of this IPF. Its growth factors often signal via tyrosine kinase. Tyrosine kinase can be therapeutic targets. Once we realize that this can be a therapeutic target used in malignancies, we have realized that we can also use it for interstitial pulmonary fibrosis. It's a triple kinase inhibitor. It acts on tyrosine kinase receptors for platelet-derived growth factor or vascular endothelium growth factor or fibroblast growth factor. And as I said, it inhibits fibroblast migration, proliferation, and also the myofibroblast transformation. It's at a stage of transformation. That is, it should be a very good drug by which it should be able to maintain the HVC and also decrease the fibrosis and make the patient symptom-free for a fairly long period. So as I said, this myofibroblast forms one of the most important pathogenic factor in the pathology of interstitial pulmonary fibrosis. It is just before the scar formation, the myofibroblast formation occurs, which gives us a different hope, saying that if you can target all these drugs, can target this myofibroblast, we should be able to make the patient's progression to fibrosis less and also delay the transplant as one of the options which the patient has to think about. And one more factor is this pirfenidone and nintedanib have different modes of action, but act on the myofibroblast transformation. Maybe there may be some studies which are not published yet. The combination of nintedanib with pirfenidone also might see the light of the day in days to come. It's available as 150 mg capsule. One of the biggest advantages over the pirfenidone or as a 100 mg capsule. It can be just given as twice a day with meals. The important side effects are like with pirfenidone, it has diarrhea, severe GI side effects, nausea, vomiting, and hepatotoxicity. And as I said, it does not necessitate a treatment. The studies which were done with nintedanib, which needed some studies to prove that it's a good drug, impulses 1 and 2 studies were done. After the initial screening, the placebo arm had 423 patients and the nintedanib arm had 638 patients. The primary outcome was the annual rate of decline in FVC, which coincided with the mortality rate. If you can arrest the progress of the fall of a decline of the FVC, definitely the mortality rate can be better. Or the secondary outcomes were time to first acute exacerbation. After starting the nintedanib, when does the patient get the first exacerbation? That becomes one of the very, very important secondary endpoint. And also the change in SGRQ, the respiratory questions. And here also, if you see, this group fared definitely much better in process one study. The nintedanib group performed much better in all respects, whether it was an FVC decline or whether it is a wall in this thing. In all the respects, the nintedanib group fared much better than the placebo. And also similarly was the response, the secondary lung function endpoints too at 52 weeks when they realized the study was quite a. The bottom line was nintedanib slows the rate of progression of IPF, and the dosing is 150 milligram capsule twice a day with meals, and side effects can be managed by reducing the dose of nintedanib. It does not warrant a stoppage of the drug. And if you compare between the pirfenidone and nintedanib, pirfenidone is a pyridoxine derivative with anti-inflammatory and anti-fibrotic properties, and by that it acts on the myofibroblasts. Whereas the nintedanib is a tyrosine kinase inhibitor with multiple growth factors. Recently, it has also been approved for progressive systemic sclerosis. It has been approved for systemic sclerosis also. And in vivo trials which are going on to see the role of pirfenidone and nintedanib, there will be some more studies which might come. I always used to feel that the drug does not identify whether the fibrosis is because of IPF or because of non-IPF ILD. If there is a fibrosis, if you can identify a fibrosis on your CT scan of the chest with confidence, I think these drugs have to be tried. I think that day will come. And Srikanth had asked this question already. Is there any way by which I think that will become the order of the day? CT scans will become one of the important diagnostic tools in deciding on whether this patient has fibrosis, and that would decide on the use of pirfenidone or nintedanib. The decline of 10% or more over 12 months is considered to be a failure in both nintedanib and pirfenidone. You stop the patient and you keep observing the patient, and you must find that there has to be a certain amount of PFT improvement. The FVC decline has to be arrested. And if there is a decline of 10% or more, that's the time when you should forcefully tell the patient that he will benefit from a lung transplantation. There is no point in trying to continue this transplant, this pirfenidone for a fairly long period. You must keep following this patient on a regular basis with a pulmonary function test. It has a positive effect on mortality, pirfenidone, whereas nintedanib is found to have a positive effect on exacerbations. It prevents exacerbations and mortality in nintedanib, whereas the pirfenidone has a better effect on mortality, but it is not shown to prevent exacerbations to such an extent. And it has to be given as 9 capsules in a day, 3 capsules 3 times a day. And nintedanib given in 2 tablets, just 2 tablets. That's one of the biggest advantages of nintedanib over pirfenidone. So whenever I give a talk, many people ask me, between pirfenidone and nintedanib, which one do you prefer? I said, I don't have a choice there because both are good drugs. Both have effect on anti-fibrotic and anti-inflammatory factors. And both can prevent the myofibroblast proliferation and also reduce the fibrosis. There is a patient who has to decide whether he wants to take 9 capsules or he has to take two tablets and be done with it. So that decision I leave to the patient. I always don't take a decision on whether nintedanib or pirfenidone. And the GI side effects and skin rashes. And GI side effects occur in nintedanib, no skin rashes. But with nintedanib, one has to be extremely cautious when you want to stop these patients when the patients are on anticoagulants. Some of our patients on pulmonary artery hypertension will be on anticoagulants. If you come from a cardiologist referral, they will be on anticoagulants for their pulmonary artery hypertension. And when you are starting nintedanib with these patients, you've got to be extremely careful because they can alter this and cause bleeding hemorrhage. And similarly, patients who are likely to go for anticoagulant treatment for their myocardial infarction treatment or cerebral bleed, or they are planning for some of this treatment, means you have to think, you have to be careful about the nintedanib use or withdraw nintedanib in such patients. And having said which are the good drugs for the IPF, the nintedanib and pirfenidone, we should also know which are the goods that are not to be used as a routine. And Panther study is one such study. Though it's a negative study, I'm making it a point to present this here because NAC is considered to be a mucolytic agent. We use it in COPD, though we are not very sure whether it benefits or not. or it's an antidote for acetaminophen-induced liver toxicity, prevention of IV contrast-induced renal failure, antioxidant, glutathione, and it is mildly antifibrotic, a questionable effect which has been used in a very big way. The Panther study, after the initial screening, were divided into 3 groups. One was a placebo group, it's 78 people, and the second group was with prednisolone, azathioprine, and NAC, and the third was only NAC. This study was primarily aimed to see whether prednisolone, azathioprine, and NAC are useful in the management of IPF. The inclusion criteria were mild to moderate IPF, and the primary outcome was change in FVC at 60. That is a study. It is primary because there were instances of steroids worsening some of the interstitial lung diseases. So we need to have some direction. So this study was designed. And so within 3 to 4 months, they realized that the prednisolone, azathioprine, and NAC group had a very high mortality and very high hospitalization rate and very high systemic acute exacerbations. So a clinical alert was raised in October 2011, and this prednisolone, azathioprine, NAC was stopped completely. And this group was divided into another 53 were added to the placebo, and another 52 was added to the NAC, just to see whether NAC was useful or not. And the study was continued longer. At the end of the study, they found that there was no difference in FVC at 52 weeks, whether it was on patient was on NAC or whether the patient was on placebo. So what's the bottom line? So it very clearly proved 2 important points. One is prednisolone and azathioprine have no role at all. So it asked why they were starting these drugs at all. So in olden days, the CT scans experts were not like Bhavin, Jankharia. There are a lot of very good people, and we have a good information on the CT scans. They're able to tell us that this does not look like an IPF, this does not look like an LD. Olden days, if you have an interstitial pattern, you used to start. If you had asked me 10 to 15 years back, our regimen was azathioprine, steroids, and the NAC we used to start. And this Panther study opened. A lot of pulmonologists stopped using steroids for IPF. They were against the use of IPF in such patients. And also similarly was the use of NAC in such patients. Immunosuppressant azathioprine also lost their role in the management of IPF. This is one of the very important study which every pulmonologist should know, in my opinion, the Panther study. Because one study, you must know about the ESSENCE study, you must know about the impulsive study, you should know about the capacity trials to know that pirfenidone and nintedanib are extremely useful drugs. They act at the root cause of the thing. And one also should know that Panther study is important because there are drugs that are harmful are being tried on this IPF patient. And if they come to a pulmonologist and you made a diagnosis of IPF, there is absolutely no role for a steroid in such patients. So in summary, the pharmacological therapy is one of the comprehensive care plan for pulmonary fibrosis. Pirfenidone and nintedanib slow the disease progression. NAC is of no use. Nintedanib is equally good in the management. So the question now comes, when to start pirfenidone or nintedanib? So we need to have some guidelines on that. So there is a letter from Raghu to this ATS journal, let's wait. So in his opinion, he felt that the day you make a diagnosis of IPF, there are people who make an early diagnosis of IPF. I've seen some of Bombay reports, people who referred to me for a transplant, who were referred to the transplant group. Bhavin has made a very early diagnosis. They referred from Bombay. Very early diagnosis they have made. So it is reasonable to argue that it has to be started as soon as the diagnosis is made. That's what one of the opinions is. But the con to this argument is fibrosis is variable and unpredictable, and the cost of treatment is prohibitive. I think people who have prescribed nintedanib would know how costly the drug is actually. I think as we write more and more, the cost of it might come down probably. But one of the reasons people hesitate to start nintedanib is the cost. That's one of the reasons they think. And the efficacy of more than 50 and less than 90 and percentage of DLCO, that's the time when you think of starting. If it is less than 30 efficacy, I don't think there's any point in starting this patient on efficacy. You must straight away tell them that you must go for a transplant. And coming to some of the biologicals which are used, the biologicals can be used either at the fibroblast level or when they are maturing into myofibroblast production, when they are being produced, if you can target them, or when the myofibroblast start accumulating, if one of these three targets can be achieved, that's what the whole research is on in IPF. There is a group which is acting on the drugs, and there is a group which is acting on the biologicals in the management of IPF. And in that, the pembrolizumab has shown certain amount of, as I said, there is a larger treatment difference from placebo than nintedanib and pirfenidone in the preservation of efficacy. It's much better than that. The advantage of it also, the side effects is also relatively less because it can be given in the form of a subcutaneous injection. It is still in the trial phase only. And this is one of the things which I attended in Italy. It was to prevent fibrosis in almost all the organs. And this is one drug which is being tried, connective tissue growth factor. It is still in a very experimental stage, but this is quite interesting to attend it. In that, IPF was one of the things. As I said, the myofibroblast activation is the one which they are targeting now. So the ineffective drugs for IPF are, one should know what we should not use. NAC is not very effective, but you can talk to the patient. Some people like to use some drugs, at least you have to try some drug. So NAC, yes. Imatinib, useless. Bosentan is not good. Masintan, your pulmonary hypertension in IPF, I don't read them, sildenafil, colchicine, they're all not good drugs at all for IPF with pulmonary hypertension because they don't help. Harmful for IPF, warfarin. As I said, some of the patients of ILD patients or IPF patients would be on anticoagulants if they are referred from a cardiologist. For pulmonary hypertension, they'll be on the thinking that this could be a chronic thrombopulmonary embolism. So it is harmful if it is IPF. Glucocorticoid monotherapy, very harmful. Combination, the cancer trial has shown, is harmful. Ambrisentan, again an antihypertensive drug, is very harmful. These are some of the novel therapies. As I said, the whole idea is to see whether you can reduce the fibrosis. So when to refer this patient for a transplant? So when the diffusing capacity is less than 40% predicted, and as I said, when there is a 10% or greater decline in efficacy in a 6-month follow-up, or a decrease in pulse oximetry below 88% in 6-minute walking test, or a resting oxygen saturation less than 89, or honeycomb. If you find honeycombing, then that's the end of it. I don't think there is any point in starting this patient on nintedanib or pirfenidone. Straight away referred for a transplant. So 2 or 3 slides on this aspect of it. The window is very important. These are some of the slides which borrowed from my transplant surgeon. He always is his favorite slide. The transplant window is very, very important for us. After assessing if the patient is too well, even though he has interstitial pulmonary fibrosis, some people, as I said, have a fairly good response. They tolerate their pulmonary fibrosis. The CT scan and the patients look maybe entirely different. So in such situations, he always is too well, you just need to wait. Or if he's too sick also, you should not take him up for a transplant. So 3 crucial questions have to be answered in affirmative. Has the patient reached the end point from the disease standpoint? Are the other systems okay, patient standpoint? So if there is a problem in the liver or if there is a cardiac problem, these things are not useful. Or have you ruled out the contraindications in this patient? The key word is in transplant is objective assessment. So one of my favorite terminology, which the person who trained me in transplant, James Robert from Pittsburgh, said the objective assessment is very, very important. You must involve as many teams as possible in transplant assessment, cardiology, everybody must involve, and everyone has to say that the organs are okay. Each expert assesses the respective organ systems and consensus reach risk quantified and benefits. And at the end of the assessment, one of the 3 possibilities will come across just a video conference. If it's too well, wait and watch and review again. It's always the video conference should be with the patient's relatives and patients, everybody. Everyone has to be involved in the group because someone will say you have done transplant too early, you should not have done it. So it's better to have a video conference. If it's too well, wait and watch, review again. Too sick, continue the treatment and make him comfortable. And transplant will be beneficial if you think, and if the team thinks, counsel and wait list, review, counsel and wait list. And some areas to improve our nutrition and physical tolerance, they go on chest physiotherapy and the them. single, double, and heart transplant, it varies. I don't want to go into the details of it. So our transplant numbers, I think it was some 1 year back, 201 organs in 111 patients were done, and 237 were assessed for a transplant. We had done about 132 lungs were transplanted, and double lung transplant were done about 30. And the success rate, 1 year success rate is about 46% around that. There are people who are going into second and third year also. It's a fairly, I think, as you said, if you want to make the transplant program to be successful, or if you want the IPF patients to be happy, you need to put two important things in their minds. One is to tell the patient that he needs antifibrotic drugs, and second is the transplant thought has to be put into his mind. At some stage, you would need a like the kidney people do for a CKD. We need to put our patients on IPF, the thought of transplant to their mind early enough so that we have a patient who is ready for a transplant if he's not doing well on his pirfenidone or nintedanib. I thank you very much for your patient hearing, all of you at this time of the hour, sitting and listening to a webinar. Thank you all. If there are any questions, I think myself and Dr. Bhavin would be too happy to take. Yeah.
Thank you, sir. That was a very, very exhaustive, and I think he has very, very beautifully talked about the pathogenesis, the fundamentals of IPF, and then the role of the new drugs, that is pirfenidone and nintedanib. I think the trials were also very nicely described, and I really think the very nice point you emphasized was the Panther trial. The negative trial was emphasized. Normally we talk about positive trials, but here I think it's important that you should know what not to use. Even now, occasionally I think we do see patients with coming with steroids, for IPF, and as you rightly said, awareness has really gone up now. And just one word I would like to share is the role of pavrilumab. We were part of the PRAISE trial, the phase 2 trial, which we conducted, and India was also part of it. And I think it is a very promising drug. It is given intravenously once in 3 weeks. The very nice part of the drug was it's well tolerated. The side effects were, when you compare to all these drugs, very well tolerated by the patients. But it was a phase 2 small number, but it really met the endpoint very, very comfortably. It met the endpoint. And I think the phase 3 has just started. So as you rightly said, we need good drugs to keep the patient as fit as possible. And at the end of the day, I think lung transplantation is probably the best way to move forward. Ajay, if there are any questions from the audience, we will take them first before we.
Yeah. We have a question from Dr. Amal. What is the role of pirfenidone in preventing IPF exacerbation? Does pirfenidone need to be stopped in end-stage IPF?
Compared to nintedanib, IPF is not all that good in preventing exacerbations. But when you have a patient of IPF with exacerbation, there is no need to stop the IPF. You need to treat the exacerbation. IPF can be continued. The exacerbation can be continued. The exacerbations could be either in excessive inflammation or maybe because of an infective exacerbation or the worsening of the disease process itself. So that needs to be treated. One need not stop the pirfenidone in exacerbations.
Okay. Then we have one more question. In progressive fibrosing ILD, is it justified to give steroids and antifibrotics?
Steroids, I still have my own doubts on that. Antifibrotics, yes. I always believe antifibrotics can be started in any fibrosis. Only if it is tuberculous fibrosis, we should not start. Any other, if it is an interstitial lung fibrosis or an interstitial lung disease related fibrosis, we sometimes find connective tissue disease related fibrosis. I think the drug does not differentiate an IPF fibrosis from a non-IPF fibrosis. And if your radiologist says that it looks like a fibrosis, ILD related or non-IPF fibrosis or UIP, I think there is a role for antifibrotic drugs, but not for steroids, because steroids are very harmful. Steroids can be given only in certain select specific situations of interstitial lung disease, like in the form of acute hypertension pneumonitis, or when you have a HSP or a NSIP like this. There maybe yes, otherwise no.
Yes, sir. I think the inbuilt trial also basically looked at the non-IPF progressive fibrosis.
Yeah,
And it
inbuilt
showed
right.
that they do very as bad as IPF. They do as bad as IPF, and it's very very important that we have proper therapy there. And I think already nintedanib has been approved for systemic sclerosis induced. Okay, more data once it gets generated from the real world. I think I agree with you that it is a common endpoint, the fibrosis. It doesn't differentiate the cause, and hopefully we
Yeah.
should be able to any
See, you
experience?
have other parameters like FVC and your all those things. They're all the same for any fibrosis, the scar tissue. So the scar tissue has to be prevented actually. So that's where the what would happen. My thinking is after 10 years, if people start doing either a cryo or a wax, which wax appears more promising to me because from the safety standpoint, if your radiologist can pick up an early IPF and a wax biopsy can be done, and if you can say that there is a myofibril mass formation, at that stage, if you get some biologicals or something like that, maybe that's the best thing that can happen to an IPF. Well, you see, our asthma management in our early days, when I was a postgraduate, there were three treatments. I used to, my emergency medical officer will give injection Avil and he'll give injection steroid. He'll say it's an anti-allergic, anti-inflammatory, antibiotic. That used to be, I completed my MD chest with that actually. After that, our knowledge about asthma has exploded so much, we are able to classify, we are able to phenotype. A similar situation will come. In that phenotyping process, the surgeons maybe I think will play a big role in that in identifying, and the radiologist will play a very big role because radiologist will identify where actually you must go and biopsy. There's no point in doing a scar tissue biopsy. They'll identify the place where they must do a biopsy, and the surgeons will play a role in modulating their treatment style. That's what I feel. Now, Bhavin is there, he can throw some light on that. He's left or is there?
Dr. Bhavin, are you there? I think Dr. Bhavin has left.
Yeah.
He was there till we began this discussion. Okay. Now,
what's your take, Srikanth, on that?
Yeah, absolutely. I agree with you totally. Moving forward, that's how the IPF profile is going to change phenotyping. So we are slowly beginning to understand there are different types. See, for example, the rapid progressors, there are some people who just do very well. And in fact, taking forward the other question, should we start nintedanib very early? I think again the impulses study showed that even those IPF patients who are mild actually had the same rate of decline as the moderate ones. So I think maybe it makes sense to treat them as early as possible. And regarding the combination of nintedanib and pirfenidone, as you rightly said, there is one trial, a very very small study.
Raghu is involved in that, yeah.
Yeah, which showed that one group was given nintedanib, another was given nintedanib with pirfenidone. The combination group actually had a better outcome, and interestingly, no significant hepatotoxicity. Because I was thinking both being hepatotoxic, this will have a additive effect, but it has not shown. But we need more study.
More
I think
data on
combination
that,
is the future, and probably India will be the first country to come with a combination pill.
Yeah.
There's one more question. Management of cough in IPF.
That's a good question. No? It's a pressing problem.
The IPF and cough, they go hand in hand. I think you need to give cough suppressants and manage it. I don't think there are any specific drugs because as the lung volume comes down in size, the receptors, cough receptors get closer. When the cough receptors are closer, they'll stimulate each other and they'll have cough. So none of our studies and their endpoints had cough as one of the important endpoints. We never thought cough should become the. So I don't think cough, you can just give a symptomatic treatment if your cough suppressant or expectorants or something like that. But I don't know. Srikanth, you have any take on that?
I think there is some data to show.
Suggestion. Is there any role for thalidomide?
Thalidomide and gabapentin. Both have been tried. Thalidomide, anecdotally, my colleagues have said sometimes it helps. I have no direct experience. But even
I generally don't.
Thalidomide has been tried. Thalidomide, then gabapentin, and some newer cough suppressants are undergoing trials. You know, these peripherally acting drugs. So, but I think thalidomide is worth a try. I have had some of my colleagues telling me that anecdotal, purely anecdotal. No harm in trying this. It's a very safe drug also.
And we have two more questions. What is the role of oxygen in IPF as an antifibrotic? And there's one more question regarding pirfenidone dosage and titration, upscaling to correlate with CT or pulmonary function test.
Yeah. First question is
Role
first
of
question is
oxygen.
what you said?
Oxygen.
Role of oxygen, in
Oxygen.
IPF
Yeah.
as an antifibrotic.
Oxygen does not have any anti-fibrotic role. It doesn't have any. Only thing is, if you start giving oxygen from day one, it is like charging your lungs. Like you charge your mobile phone, you charge your lungs. And if there is not much of hypoxia is known to release certain mediators which can cause more fibrosis in them. So to prevent a baseline hypoxia, you suggest oxygen right from day one. People should not think that it is a pranavayu, you must use it only in the last phase. Many people have that kind of an impression. But oxygen, on day one, oxygen should be used. There are two things which you suggest on day one when you make a diagnosis of IPF or ILD. One is the oxygen, or second thing is you might worsen. If you worsen, you might need a lung transplantation. I think that has to be told on day one. I don't think it should be told after 4 or 5 years. The oxygen does not help. Number two is pirfenidone dosage. I don't know about Srikanth. My dosage, I have maximum gone up to 2 caps 3 times a day, not beyond that. 3 caps and all. None of my patients tolerate 3 capsules 3 times a day. I don't know what's others
Do you
expect.
correlate it with the CT chest or a pulmonary function test? That is one question.
Pirfenidone. Pirfenidone is with, you start the patient on pirfenidone based on your CT scan features. After this, stepping up depends only on the pulmonary function test only, which we'll be doing every month to see whether he's improving or not. That's why it tells whether 1 capsule is enough or 2 capsules is enough. If there is no decline in pulmonary function test, or if the FEC is maintained, DLCO is maintained, during the 3rd month or 4th month with your 1-1-2 dosage, I maintain with that itself. Srikanth, you were about to say something.
No, this question pirfenidone. I look at it like this. The dosage I would like to go to the maximum dosage, because all this data you see is on 1800 to 2200 milligrams.
Yeah.
But the problem is very few patients I am able to reach that level. Before that, there is intolerance. Patients usually default.
Yeah.
So if I reach that dose, I wouldn't titrate. I would like to continue the same dose, because that is the one which has given maximum benefit. So optimal dosage, you reach the dose and continue the dosage by monitoring the LFTs. I don't titrate based on improvement, or many a times I have not reached the full dosage. That is where
Many times we have not reached that dose at all, actually.
That is where nintedanib really scores. But then the pill load is very high in pirfenidone. The cost load is more here. Two different loads. This is so expensive. That's a generic drug. So nintedanib is well tolerated, I'll tell you. I have not seen patients, even in the trial, very few people actually
complain of
all of them completed. Diarrhea is very much manageable.
Okay.
So it's a question of tolerance and financial ability to pay for that.
I think once more people start using it, the cost will come down. Yeah.
Hopefully. Today
we have some questions. Yeah. What is the role of pulmonary rehabilitation in IPF? Is it useful in clinical practice?
I think I tell my patients not to go for active exercises like walking, long walks. Those things I avoid them. But I tell them to do anything that is isometric. Sit and do exercise like your pranayamas. All those things I suggest, but not physical exercise which involves, because any increase in thing causes more problems to the like isometric. Yes, sit and do whatever you want to do, you do it actually. But this in contrast to a patient who has undergone a lung transplant. When he got to go for a lung transplant, I wanted to develop some muscle. So we hospitalize and then give them active exercises so that his limbs and things get better. So that after the lung transplant, he has power to breathe and power to walk and so on. Srikanth, you want to add something on that?
Nothing. I don't think pulmonary rehabilitation. It's very complicated.
Only in the pre-transplant phase, it has a very big role actually. When I think of a transplant, when I think he is very thin and puny, I tell him you must go for a. That's why the cardiopulmonary exercise, this thing, CP department becomes extremely active. CPET department is extremely active only in that.
I'm not aware of any pulmonary rehab data. Maybe I have no experience at least, and I've not seen anybody doing much of rehab in this group.
Yeah, IPF, I don't think anybody does.
Okay. As a thoracic surgeon, I have a couple of questions at this juncture. A lot of patients refer to me for lung biopsies, VATS lung biopsies. So my thing is their baseline saturation is only around 90, 91. So many times we find the anesthetists are also a bit hesitant or extra careful in doing all this. So I just want to know whether these patients are being referred to us late, or is there a role for surgical lung biopsies in all cases of ILD at the moment you make a diagnosis, or what is the window? You have a window period where you can undergo this surgical lung biopsy before transplant, or in decision making whether to start the patient on pirfenidone, nintedanib, or other medications and all that stuff. So I just want to know, because the patients are really tricky. Even though the surgery might be easy, in these patients, the surgery becomes tough. So I just want to know what is the role, or what is the exact timing where, I know it's difficult, and Dr. Bhavin will also be a good person to participate in this discussion, but unfortunately he is not here right now.
You see, first and foremost thing is whether the biopsy is needed in all cases of interstitial lung diseases. The answer is yes. You need a diagnosis, because as I said, another 5 or 7 years down the line, it will be an entirely different ballgame treating IPF. It will be like treating asthma and COPD now with drugs and biologicals and transplants and so on will come into the picture, which means you need to have a biopsy. The biopsy question is whether you can do a cryobiopsy or whether it can be a VATS biopsy. That's where the question comes actually. So I would say if the radiologist can diagnose at a very early stage and that he can sense and say that it's likely to have a subpleural fibrosis, and the subpleural thing suggests that it is interstitial pulmonary fibrosis, IPF-like thing is there at a very early stage when the saturation is above 95, 96. That's the best time to do a lung biopsy. Give the direction to the treating pulmonologist as whether he can go for a drug treatment, or whether you should also tell the patient about maybe some biological related date or transplant and so on. You have a good diagnosis. But when the saturation is around 90%, I don't think it is worth risking the patient either for a VATS biopsy or for a cryobiopsy, because it is not worth taking that risk. Because as I said, if you think 90% saturation, patient is worsening about 55, 56 years, you need to make a decision on whether it is sarcoid or non-sarcoid, when the patient 90% saturation becomes. So in such situation, the CT will be the best tool. If you have a perivascular bundle or a perilymphatic bundle, sarcoid can be the diagnosis, where you can take a biopsy. In sarcoid, what happens, our observation, I think you should agree, is the 90% saturation is maintained during the bronchoscopy, during the biopsy, lung biopsies too. So such patients can be diagnosed with a routine transbronchoscopic lung biopsies, which means at 90% saturation, VATS is something which I would not recommend for LSC. I come to Srikanth after that actually. Then the treatment decisions, yes, you were asking for treatment. Yes, definitely the treatment decisions will depend on the biopsy. If you have a good thoracic surgeon or a good pulmonologist who can get a good tissue, and a good pathologist who can type the tissue. We also had a patient who was labeled as interstitial pulmonary fibrosis, who was given a Dooms diagnosis, who came to us. We did a VATS biopsy and gave her a diagnosis of sarcoidosis. She's doing so well now. She called me 6 months back. She's 6 months old now. She's on steroids. She's doing well. She's on a tapering dose of steroids. So biopsy, definitely, if you have a diagnosis, it is good only, definitely. But at 90%, my take is not there either for a VATS biopsy or for a cryobiopsy. Srikanth, what do you feel?
Yeah, absolutely, Ajay. It will depend on what I'm suspecting. For example, if it is a classic UIP pattern and a person like Bhavin giving me a picture, I wouldn't go further beyond
Go
that.
for a biopsy at all, yeah.
Yes, I wouldn't go.
There also, the question comes, Srikanth, when you are thinking of sarcoidosis. That's the only thing. This lady I was telling was, she had an picture-like UAP pattern, but her CT scan showed features suggestive of a perivascular pattern, where we had to make a differentiation. That's where we asked the surgeon to go and do the biopsy. So did the biopsy, there was a telltale evidence of sarcoidosis, non-keep setting granulomas. Classic picture was there.
It will totally
So our
depend
job
on
was
what
easy.
etiology and what we're suspecting. I feel biopsy does have a role for sure, but then with such a ILD is a conglomeration of so many diseases,
It has a role.
from infection to drugs to malignancy, the whole lot. So what I'm suspecting, I think depends on that. End stage malignancy, I wouldn't do anything.
So your pre-test probability plays a very important role in
Exactly.
directing
Yeah.
your
True. Correct.
intervention, and
Yeah.
then
And at an early stage, one is a pre-test variability, but the pre-test variability also, if they come to a later stage, 90% is not worth it. I don't think we should subject this patient to the risk. It is not worth taking that risk at 90% saturation.
it doesn't go. It's not going to make a difference or reverse the fibrosis even if you
Yes.
start them on antibiotics.
Yeah.
Yes.
Okay. So we have a couple of more questions. Sir, does antifibrotics increase the chance of infection in IPF? Is prophylaxis needed? Antibiotic prophylaxis?
Don't think there is anything like that.
Yeah.
I don't
think
so. There is no evidence in that way. It doesn't.
Then what is the role of pirfenidone in fibrotic NSIP or end-stage fibrotic sarcoid? And one more question from the same person, Dr. Sridhar. Antifibrotics, do they need to be stopped before transplant? If so, how many doses before?
Antifibrotics need not be stopped before transplant. There is no need to stop the transplant. Steroids, if it is on, we need to stop the transplant. Steroids need to be stopped because steroid prevalence can cause problems in the immediate transplant phase. Antifibrotics need not be stopped. You can continue till you do the day before the surgery. Also, antifibrotics can be started. The other question was
whether they can be used in NSIP and other.
Yeah, that's what the inbuilt trial is all about, the process. I think my opinion is yes. I would say yes, start the patients on.
But I think the message I would like to say is, as of now, there is only published data for IPF and scleroderma and rheumatoid ILDs. All others would be off-label use. It would be off-label compassionate use. So if you want to be correct on that, it should be an off-label use. But I think logically, it should be effective. We'll probably wait for more data on that.
What is the role of anabolic steroids in IPF? Yeah,
Nothing.
somebody has asked, can you please give the reference for your slide on biologics in ILD for further reading? I think we can make that available to him in the chat. So we'll do that definitely. So what is the role of anabolic steroids in IPF? Does it improve muscle strength?
No.
Okay.
Straightforward, no answer for that.
No.
It does not improve in TB itself. There are a lot of studies who used to give a lot of anabolic steroids in TB too.
Yes.
It doesn't improve.
Yeah. Yeah, true.
Is long-term proton pump inhibitors needed in IPF? Problems?
Yeah, that's a topic we have not touched at all. It has a role actually. GERD is considered to be one of the thing in perpetuating the IPF. I see Raghu has got a paper itself from University of California where they have gone and done a fundoplication for all patients of IPF to prevent worsening of interstitial pulmonary fibrosis. I think that's not a very great evidence for that actually, whether it prevents fibrosis or not, because there are better drugs available now. See, the idea is now you are able to identify the pathology, identify the pathology from fibrosis to myofibroblast to myofibroblast maturation and accumulation. That's the whole path, and whatever research is going only towards that. Whatever you do, though you go and do the fundoplication, they will prevent the acid. Actually, the disease itself, the process is going on there. So that process has to be arrested either by one of these mechanisms, either by the biologicals or by the drugs, or the drugs that are going to come into the market will be directed only towards this fibroblast to myofibroblast maturation. That will be the goal.
In fact, the recent, I think ATS joint statement clearly says, as a routine, no need to use proton pump inhibitors as was advised before.
Our own guidelines, Lung India also we have said that. This month it has been published.
Yeah. I have just one question. Maybe I think it's time before winding up. I'm sure you're seeing this combination of emphysema with fibrosis, CPF.
Yeah.
So how do you manage them? Do you treat the pulmonary hypertension aggressively in that? Because they have a higher mortality. Do you treat them differentially, or what is your?
I treat them as two separate diseases. But one thing that I don't do is to start the patients on pulmonary hypertension drugs, PAH drugs. I don't start them on. If the patient has a PAH with IPF, my stress would be on oxygen to tackle the COPD and IPF both. And anti-fibrotics, we can start them on. And the newer one that have come now, the latest generation drugs which have come, this glycopyridine and other things, they must show some promise. The way they are being touted as, though you rightly said, last, we don't have much evidence or much data on that. I think the way they are being promoted and some of the studies which have come, they show a good progress, and they should be helping the patients, especially the glycopyridine, formoterol, fluticasone combination should be good in helping these patients of emphysema with steroids in IPF2 such patients. We do come across, and it's quite difficult to identify. You need to have the great lateral thinking to identify that this patient has a coexisting IPF along with emphysema.
Okay.
I have one question, last question to sum it up, because ultimately the thing is going to end in transplantation for most of the patients, because that's what you were emphasizing in your talk, that seed of the transplant, the thought of transplant should be sowed in his mind early enough so that the acceptance level is more. Is the final word out whether these patients require single lung transplants or double lung transplants? Because there was a never ending debate all through my PG life. There were a lot of meetings. There's always a topic whether single lung transplant or double lung transplant for ILD. I'm not much into transplant surgery, but I'd like to ask this question for the benefit of the postgraduates, because a lot of people will be attending their exam shortly. Will you recommend a single lung transplant or a double lung transplant for interstitial lung disease?
For interstitial pulmonary fibrosis, the transplant of choice is double lung transplant only, not single lung transplant, because the acceptance rate is much better in double lung transplant. Single lung transplant, you have a problem, overperfused lung, the other lung suffers, and the other lung becomes infected. The transplant lung from this lung, native lung, so keeps sending the problems to the transplanted lung. So a lot of problems you have in a single lung transplant. We did try. Our first patient in Apollo Hospital was a single lung transplant. Had a lot of problems. We really wondered whether we did the right thing in suggesting a transplant to this patient. A lot of problems we had. He did for 6 months, but we had a lot of problems with that patient. After that, we started doing double lung transplant. Double lung transplant definitely is much better than a single lung transplant, because you remove both the lungs, and if the problem occurs, both the lungs have to be handled, and they do well, double lung transplant compared to the single lung transplants. I think there has been a recommendation that for IPF, it is better always to suggest a double lung transplant than a single lung transplant. Is some certain specific situations you think of, like in a cystic lung disease, unilateral or unilateral extensive bronchiectasis, you find congenital something. But basically, you don't find anything on the left side, or predominantly on one side only bronchiectasis. In such situations, in children, you can suggest a single lung transplant, not a double lung transplant in such patients.
Okay. And just to sum it up, because this is a COVID era, we recently read about one patient undergoing bilateral lung transplant in a post-COVID state in US. One of our Indian origin surgeons was leading the team that did it. So what would you recommend in this COVID era?
I would not recommend a transplant for a COVID patient. No transplant for an infection guy. Srikanth, your talk.
Yeah, that's what even I was thinking, but it was
Your
hailed
thoughts
as
on that? One Indian surgeon doing a transplant on a COVID patient. COVID is a systemic disease. How can you transplant lungs and then make him all right? I think in my opinion, it's not a right thing. I wrote to ACCP itself, actually. Why should they publish this article?
I mean, I would look at you. I don't mind any transplantation in COVID, but not for COVID.
Yeah.
In transplant, in COVID times, any transplant is okay.
Yeah.
Correct.
Like
that's
we do
right.
surgeries. We do so many surgeries, bypasses going on, even.
Yeah.
But this is, I mean, you don't need it. No, it's an acute illness.
It's an acute illness, and it is not a disease confined to lungs only. It's a disease systemic illness. I don't think there is any role for a SI.
I don't know what that indication was. I have no idea about it. That I read about it, but
acute respiratory failure.
The reason for doing transplant.
Yeah, I got the letter from them. It's an acute respiratory. That's why they are done it. Okay.
Anyway.
I think last question. There's one question. I think bronchodilators in IPF, can inhaled corticosteroids be used?
No use.
We'll finish it
Inhaled
up.
bronchodilators don't have any role. On the other hand, there is a certain amount of bronchoconstriction occurs in these patients because of hypoxia. And this hypoxia-induced bronchoconstriction and vasoconstriction is the cause for some bronchospasm and pulmonary hypertension, which means they are all defense mechanisms for the body. That's why you should not give pulmonary vasodilators in pulmonary hypertension and bronchodilator, because you go and give a bronchodilator to a patient of IPF with a bronchospasm, the ventilation pressure imbalance gets worsened. So they look more dyspnea. Paradoxically, there will be more dyspneic. So you should not give it. The only indication where inhaled steroids can be given for an interstitial IPF pattern is sarcoidosis. Actually, we have a paper, myself, Jindal and all, we have published a paper where you can give inhaled corticosteroids for patients of sarcoidosis. If you have a sarcoidosis, instead of giving oral steroids, you can try inhaled steroids in a very early phase of sarcoidosis. That is stage 2 sarcoid, asymptomatic, but CT scan showing features of interstitial sarcoid pattern on the CT scan, biopsy showing sarcoidosis. In such patients, steroid has a role. Otherwise, it has got no role at all in this. Okay, Jay, 8:10 now. I think we'll give it back to Sun people.
Yes.
After Srikanth sums up. Srikanth, you can sum up your comments.
I think it was a wonderful webinar. Yes, Ajay.
Yeah.
I think it was a wonderful webinar. Both the speakers really brought out the important aspects, and their interaction was very good. The quiz was very interesting, and thank all the participants who really made it lively by the quiz. After all, it is the feedback and questions which are very, very important. And I'm sure that during these times we will have more such virtual webinars. And now I once again thank Ajay. Wonderful. It was great having you on board. So look forward to more interaction with you too. Yeah. So back to Sun.
Yeah. So hello, Dr. Yogesh here. Actually, I lost connection in between because of some technical glitches. In Mumbai, it is raining cats and dogs, so this connection problem I faced. So I thank today's speaker, Dr. Bhavin, who has left actually, and Dr. Narasimhan for lucid presentation on such a complicated topic. Dr. Srikanth for moderating this session. Dr. Ajay for, in the end, such an interactive and the question and answer session touching almost all aspects of disease as well as management part. I also thank audience who joined for this webinar from different parts, and entire backend team for doing all the arrangements without which this webinar would not have been possible. So thank you all and stay safe.
Thank you.
Right, thank you. Thanks, Srikanth. Thank you.
Thank you.
Thank you. Okay. Yeah.